is all C. diff the same? That is to say, in terms of cultures, are there various strains? Do these strains have various, if you will, toxicities? And is one C. diff better than another? If you're going to have C. diff, which would you like? Who wants to start on this one?
Well, it is clear that all C. diff are not the same. And prior to about the year 2000, I think most people viewed C. diff as somewhat of a nuisance illness, that it was not as devastating as it is today. And part of the reason that we've seen a marked increase, 3 times as many cases now of C. diff in the United States, is due to a strain that appeared around the year 2000. It goes by a complex name of BI027 and NAP1, which is just 3 different ways of classifying typing. And that strain spread from the United States, Canada, into Europe, and has caused marked increases in C. diff rates and in C. diff mortality, and has accounted for as many as 30 to 60% of all cases in the United States during the early 2000s. It is now declining in the United States, and CDC this year, for the first time, reported that the NAP1 strain is no longer number 1. It has been surpassed by a strain called ribotype 106. But this strain possesses 3 toxins, A, B, and then a binary toxin. And it's thought that the binary toxin is contributing to the severity of illness with this strain. So the strain type really does make a difference. And clearly, I've never seen a severe disease as I started to see when we started finding this strain.
There are, just to build on what Dale was saying, there are a few factors that make this strain more virulent than other strains. One is that it seems to make more toxin than other strains, and another is that it has innate resistance to fluoroquinolones. So patients receiving fluoroquinolones are at increased risk for getting this NAP1 strain that he described.
So again, if you think that antimicrobials are selecting out, leaving the C. diff alone, this one's more left alone than the other ones, ergo it's more likely than it was before.
Certainly in patients who receive fluoroquinolones, and in both the community and even more so in the hospital setting, this strain is, if not number 1, certainly among the most common.
And I mean, fluoroquinolones are ubiquitous, right? I mean, you call your doc, you say, I've got a cold, and the doc may, in fact, give you a pack of fluoroquinolones to take for however many days.
And fluoroquinolones can actually be associated with any type of Clostridium difficile, not just this strain. But interestingly, this strain may be also associated with higher recurrence rates, which is one of the main issues with C. diff, unlike any other infection, and also may be less responsive or treatable by some of the antibiotics that we've been using. There has been some data that show that there may be higher resistance rate for this strain for metronidazole, which is one of the most commonly used anti-C. diff antibiotics. And that may be also one of the factors that contribute to the severity of disease, that people get metronidazole. It may not be very well. As you know, when we have patients with C. diff, we don't have a culture, we don't have susceptibility testing, and physicians treat it with less guidance as compared to other infections.
But you do have PCR, you have genetic analysis.
Yeah, we do have a PCR, but the PCR is just for the toxin B gene, so it doesn't tell you what strain of C. diff it is. One of the things I've always wondered is why there isn't more vancomycin resistance to C. diff. Why, with all the use of oral vancomycin, it hasn't developed?
Anybody know? I mean, we use vancomycin like water.
Well, I mean, actually, to develop vancomycin resistance, it actually requires several genes. So it's not like a single point mutation, but it's a pretty complex mechanism. And, you know, at this point, I'm not aware of clostridial strains that are inherently resistant to vancomycin, which might maybe facilitate a gene transfer event to C. difficile. And also part of it is also the levels of vancomycin we get in the colon, even with 125 milligrams 4 times a day, which is the standard treatment dose of vancomycin, you're getting levels of vanc in the colon that are probably at least 500, if not 1,000 times higher than you need to kill C. diff.
Well, are you familiar with metronidazole resistance?
Well, I mean, true in vitro metronidazole resistance has not been described, but part of the caveat there is the metronidazole susceptibility breakpoints are based on serum levels of metronidazole, not the amount of metronidazole that you get in the colon, which is several-fold lower than what you get in the blood and is highly variable and also decreases over time as the inflammation resolves.
And it's also definitional, right? Because resistance is really a grayscale. You're resistant when you have X number of dilutions of this antibiotic that no longer inhibit bacterial growth, but if you give enough, maybe it will. So to some degree, you've got to define what you mean by resistance. Nothing necessarily is completely, absolutely resistant, although some may be.
But it's only one determinant of success of therapy, and it is important to remember that even though there's no resistance to vancomycin per se, not everyone is treated adequately or being cured. And in fact, when we talk about the consequences and mortality, this is despite of adequate therapy.